Welcome everybody. It's the 9th of October 2020 and this is the 21st COVID UCD seminar series. I'm Fiona McNicholas, Child Psychiatrist, and I'm delighted along with my co-host Dr. Bláthnaid Gavin and Paul Harkins from UCD to co-host this along with the College of Psychiatry in Ireland. So again, lovely to see new names coming back, familiar names, and people both from psychiatry and outside. Everybody's familiar with Zoom now. There's no need for me to continue to mention that, other than to say that all our videos are recorded on the UCD Child Psychiatry website. And I've been listening back to them myself at various times, and really they have been excellent. We're in for a treat today also because I'm delighted to present our speaker, Dr. Mudasir Firdosi, who is a psychiatrist who trained in Kashmir and did his medical and his psychiatry training there, and came to the UK where he's a member of the College of Psychiatrists, and he's a consultant psychiatrist and an honorary senior lecturer in St. George's University Hospital. But Mudasir, in addition to being a psychiatrist, is also a writer, a poet and a health advocate. And indeed, much of his writing, I understand, I haven't had the pleasure yet, Mudasir, of reading it, but relates to traumatic situations, conflict situations, health advocacy. And I think that what you're going to be talking about today, which is COVID-19 and the management of that in your acute inpatient psychiatry unit, will be very, very interesting to the group. So thank you very much, Mudasir.
Thank you very much, Professor McInnes. I should first thank you and UCD for inviting me to give this talk. I understand I gave a brief talk to Royal College about COVID on an acute psychiatric ward, wherein I didn't use any slides. I was just talking about the experiences and how we were dealing with it at the time. But given we have a bit more time today, I have made some slides for that fact. So just to give some context where I work on an acute psychiatric ward. We admit patients between ages of 18 to up to any age actually, unless they have to go to older persons unit. I work on a male only ward, interestingly, and my ward is based in a general hospital, which is part of the St. George's Acute Trust. Although I work for the St. George's, Southwest London St. George's Mental Health Trust, and we have got few sites. I think overall we have 10 to 12 wards on the acute side, and then we have forensic and specialist wards as well. So just an overview, what I will try to sort of talk today would be more personal experience. So I'm not giving an academic talk where I would be dealing with numbers or research per se. I would try to focus more on the ward-based situation, how things change and what happened. And I would talk something about how the organization overall, the whole trust and organization dealt with it and how the changes came through. And I would be happy to take any questions if you have at the end. So obviously it started way before March, and gradually it was March when everything kind of came together. I remember, I think initially there were kind of rumors coming in. The situation was quite uncertain. I think we were talking to each other as colleagues in the teams, with consultants, with nursing colleagues, that how is it going to be, given the only solution seemed to contain the problem was to keep away from each other. And that was something which you can't do actually on the wards, and more so on psychiatric wards where people come in acutely unwell. I think there wasn't much time to think, I would imagine. We tried to organize a meeting of inpatient consultants at some point with our associate clinical director. But before that, the lockdown started. I think it was 16th of March when the government sort of put the lockdown. And with that, certainly our trust, what they go into the silver command, gold command, means that kind of the decisions would be based from top to down, and clearly guidelines started coming down every day. There was kind of bombardment of things. So it was coming from Department of Health, Department of Public Health, then kind of similar guidelines were being circulated at the time. So similarly, all the teaching was suspended. So medical students were gone. I had physician associate students on the ward, medical students, and any other student that was completely suspended. And finally, I think we did manage to meet. I remember having that last face-to-face meeting on 19th of March. I think since then and now, we haven't had any face-to-face meeting whatsoever for anything. We're just on Teams or Zoom, where some colleagues were present, some were virtually present to discuss what to do, what not to do. But overall, things were quite uncertain. And I remember going to hospital then when the lockdown started. It was really scary. Outside, normally it's a busy place. You would see people coming in the morning, people around reception. Like in the hospital I work in, there are like minor injuries unit, there is a GP surgery, there are other sort of units of neurology and others. You would see no one walking. You're just going in like into a war zone where everybody is in because something is going to happen. And when you arrive on the ward and you would suddenly feel like everything is normal and people are like shouting, there's things happening, and with this fear on us that what's going to happen. I just mentioned earlier, so there was this confusion and uncertainty, like how we are going to deal with it. The questions that obviously on acute wards, you cannot kind of keep distance, and even if there is space to keep distance, why would you keep distance? Like you have got 20 patients who are there day and night, and it's like a family. They would have to eat at some point in the dining area or do some groups. Or if you're very unwell, sometimes you need to go closer to the patient. You need to give, for example, injections, or sometimes there are physical restraints which are unavoidable at times. So that wasn't changing. And the protocols were coming so quickly, it was hard to keep pace with them, to read them and just follow them. And I think you probably all know that when initially the problem started, PPE or the personal protective equipment, there wasn't much. I think it's not a secret. So it was more based on supply. The guidelines were mainly based on supply rather than on demand. And for a while, UK government and then everyone was kind of disputing whether you need to wear a mask or not. It was all over the place, I should say. And I think many of the trusts in England, I would say, gave scrubs to the staff on mental health wards, but our trust took a different view, and we didn't do that. I remember I ran out of shirts in a few weeks' time because it was difficult to, and personal thing is that our washing machine also broke down, which I had to change during this thing. But then I basically bought T-shirts which could have a round neck, which I would go in, and they were easy to sort of wash. That's how the situation was, and we were having regular sort of Teams meetings with management, and it was, I think nobody actually knew who was right and who was wrong, what was the best thing to do. So many people would argue, oh, we should do this. Some people say we should do this. But ultimately, it did work out. I think there were disagreements, agreements, and heated debates, I remember at times, and people were upset. Clearly, people were emotional as well because it was about their safety, not only about their safety, their family's safety. You're going home in the evening, you don't know whether you were with someone who had it, and were you keeping safe or not. So that was not easy to deal with, and this was happening like day and night. So then, this little man, he is my son. I think he was 3 months by then, and we had to go give him his second immunization regime. We went to the GP surgery. I remember going to GP surgery, and they wouldn't actually open the door. They would ask, who are you? Why are you here? So we had an appointment. Anyways, they gave him the jabs. We came back. I went back to the hospital after that, and my wife called me that she's got a temperature. So what happened is that clearly there was no testing available. So following the protocol, I had to self-isolate for 2 weeks. I don't think it was COVID or anything, but then that led to this whole new world of doing ward rounds from home. So through the junior doctors, quite efficient junior doctors, they managed it. So I would sit on the computer and then they will get the patients one by one in the room. We have a video conferencing big screen on the ward, which is connected through Skype. And so I would see patients, but I think by early next second week when I was home, one of the patients got angry and he tried to throw the chair on me. Well, clearly it hit the screen and I broke it down. So that's kind of a background how it was working. I would kind of further like to talk about a bit more in kind of about how patient dealt with it, how patients' families, carers dealt with it, and what happened with the staff on the wards. So I think I did allude to this before. Distancing, social distancing. Although we talked about it, we tried it. It wasn't possible at all. So completely. We literally gave up on it. Even when we have a big conference room where you can see a patient, if you have got 2 junior doctors, a nurse and a patient, you still get 4 or 5 more than people in the room. And similarly, on the ward itself, people were mingling quite freely. That wasn't possible. So PPE, as mentioned, and at that time there was no testing. I remember we had few patients having some cough and temperature in first few weeks when this started. And essentially, we made phone calls. We called our infection control nurse in the trust. Even our clinical director got involved. The lack of clarity was really frustrating. And ultimately, we had to kind of try to keep them isolated in their rooms. They recovered, essentially. Probably, we don't know whether they had it or not. And with that also, most of the activities on the ward came to standstill a bit because all the groups and other stuff which people would come from outside to do, they were not able to do it. So in a way, it became a boring place for patients, I would imagine. And they, apart from taking medication and having some kind of one-to-one with nurses, the other activities stopped, which wasn't helpful. And then during the earlier March, April, there was a fall in admissions, and I can show you a bit later on. I got a few graphs there. And at the start, people were getting admitted to any ward. There was no, our trust didn't go for kind of like we will admit COVID patients to one ward and then we'll transfer with keep green or red zones. So any ward would get any patient. There was no discrimination. But later on, when the national guideline changed that every hospital should have separate wards for positive, negative patients. So I think that's what we are following at the minute. And clearly there was this whole huge stress on that we should try to send patients home so that that is the safe place for them. Which did happen actually, which I think the problem was again then there was not much testing available. So we did send people out, some of them who we thought were kind of ready. I'm not sure whether they carried any infections with them or not. So this is from one of the emails we used to get at the time around March, April, that we identify patients who can go home and have a discharge plan. And patients who are at high risk if the ward is working, reduces staffing. So we had to kind of try to sort of triage patients if things don't go well, if too many staff go away. And also if someone gets positive test or they show symptoms, would they isolate or not? I think it did help to some extent to sort of keep things ready in a way, but then there was not much time and much staff left, and everyone was kind of in a way helpless in front of this unseen entity that it had taken over everything. So everything else stopped basically. This is from the NHS benchmarking, so you can actually see that this is the first time there was kind of a reduction in admissions in the acute wards. And from our hospital trust point of view, we had first-time beds. So my ward is always 100%, and there are always patients waiting to come in. So we had first-time beds, and we actually managed to close down one ward, I think, in April for a few weeks. Then essentially the referrals again came more and more, and it opened up. And you can see by July, the admissions were kind of, this is national, this is not my trust, were kind of 90%. So what happened to our trust is that we classify kind of bed state as green, red, black. We went to black because we had more patients than we had beds. So they had to procure beds from outside the hospital at some point. Coming back to patients, I think it was really surprising to see that despite what we thought about, most patients actually respected the rules. I remember talking to patients about leave. So there was the national guidelines that you have to go out only once for a walk or something. That's what we actually did. We changed the leave situation with patients. The patients who were detained under Mental Health Act, it was a bit easier to just kind of grant them once a day leave. And patients who are in hospital informally, they kind of agreed with us, and that was what was happening for a bit. So it did even restrict them, and they would have to stay in. Ultimately, visitors were stopped to visit the wards. And I think with that, they also lost many of the advocacy services and other things which were coming to see them off and on. I already mentioned about testing and self-isolation. So whenever we suspected that there was some patient was showing symptoms of COVID, I think overall it got really well. We had finally at some point 2 patients who tested positive. Both of them actually stayed in their rooms for 2 weeks, and although they were mentally quite unwell on one hand, I think one was manic and the other one had psychosis. They managed well. How did they cope? I think it's difficult because clearly I think they coped better in some sense because they were still with people. There were still people on the ward and they had each other. But I will talk a bit later about the type of patients we got later on in this COVID. Is that people who were home were not coping that well because they were more isolated. So there was still some company on the ward, and there was something to do, someone to talk about. But clearly, it did affect the overall treatment process in general. Similarly with families, I think I had few patients whose families would regularly come to see them and also attend meetings. And we also run a family clinic on the ward weekly, where kind of 1 or 2 sessions with families if there are difficult dynamics or something like that. That had to stop. Then the family visits had to stop. Ultimately, it came down to sort of phones, and sometimes if families could attend through online, Zoom or Skype, that used to work. But we still had some families who were desperate. The son has come first time in the hospital. They can't help. They will just come to the door. And I did actually see some, because I think at the end of the day, we had to sort of be more human rather than. So at some time I did see some families, but that was kind of in kind of their desperation, and because they were there outside the door and wanted to know what's happening with their loved ones. And later on, we did kind of, when there was some relaxation in rules, so we did sort of start sending patients out. They could see their families outside in the grounds with some social distancing and with some PPE, but definitely not an easy time for families as well. There's lots of worry. Obviously, the worry was also that the loved ones in hospital and they are high risk for getting COVID there, rather than if they were home and they would be well off. It also sort of increased kind of, I would say workload probably, as you had to make more phone calls, kind of try to be more available and reassure people in that way. So you probably know, so we often get visitors, professional visitors to the ward as well, like mental health advocates who advocate on behalf of patients who are detained and can't advocate for themselves. they couldn't come. They are still not coming, and I think they're just doing the phone or video, which in my understanding is that patients who actually need advocates, they don't ask for them. It's only the patients who probably advocate for themselves ask for an advocate. I think it's still people are at disadvantage. Solicitors for the mental health tribunals equally, if they are needed, they are still doing. Chaplains are not coming. We had a music group on weekly on the ward, which is still not happening. We had a PET session for patients, still not happening. And other allied services like podiatry, physiotherapy, dietitians, other people. So everything kind of stopped in a way. Not as their fault, but I think the guidelines came through that you minimize contact, stay away. But I think gradually now some of the people are coming back. But I think still patients are not getting the full deal, definitely. And as you know, the Mental Health Act in UK or England, where on my ward, mostly I have detained patients because it's a meal-only ward. I usually get some of the patients transferred from other wards who are difficult to manage in mixed ward, like disinhibited patients. So that was another challenge. I think there was a period when social workers would find it hard to come to the ward because they were worried. They were worried that they will get it. And obviously the tribunals is another thing. So that was a very interesting experience. Normally we do face-to-face tribunals where there would be a judge, there would be a medical member, there would be a lay member, then there would be patient solicitor, patient's care coordinator. So it's like 6-7 people, then the consultant from the ward would be presenting evidence. So at the start, that stopped completely. Then initially the tribunals was a single bench where there would be only the judge who would do a phone tribunal. And then you will call in. So there would be no face-to-face contact. And we had this very challenging situation once. We had one patient who was COVID positive. He was isolating in his room, but he applied for a tribunal. The difficulty was we were not able to keep the nurse close by to the patient, and the judge refused to give the number directly to the patient so that he can call in. It took us a good he was trying, it took him good 2 hours to find out whether he can pass on his number to the patient. And finally he gave in, and it did happen. Those kind of challenges. But later on now, what is happening is the tribunals are happening full bench, but still on video. So there is, everyone is calling from their homes, basically the judge, the medical member, the lay member, and the patient and nurse calls from one of the computers. I log in from another computer. It is taking longer to do these hearings, but I think they are better than the telephone hearings, but still challenging. And still sometimes the connection breaks down and not easy. And they are not straight away giving decisions to patients at times. They take their time because clearly when you see someone face to face, you get that feel of the situation or feel of the person. The virtual situation is sometimes I call it lifeless, or it can be just something not real in some sense. And also, as per Mental Health Act in UK, you have to call a second opinion doctor from Care Quality Commission CQC if someone is detained for 3 months. If they don't have capacity to consent for their treatment. So that also is now a more process on phone rather than they coming and seeing the patient physically, which obviously I would think is in best interest of patient when they are seen by a senior psychiatrist who reviews the treatment than having a telephone consultation with the patients. And most often some of the patients, they don't want to talk to them because they think they're just another doctor trying to bother them. I think I did mention some of the things about treatment options on the ward. So clearly the groups completely stopped for a period of time. We had a walking group, the other groups. So we are just reinstating some of these groups now, although the second wave is on its way. But we still, it's not still fully reinstated. So electroconvulsive therapy, that was another thing which became challenging. Clearly, this was considered to be high risk treatment option because you have to go close to the patient. And I think for a period of time, we had to very be carefully selecting patients, and only like when nothing else could be done, ECT was an option. So there was some delays in kind of accessing the service, but it's back to normal, I would say now, although ECT is not much used these days. And then the difficulty was all our patients have got some physical morbidity, and referrals to physical health care became a nightmare, because most of the, still, one, they were not seeing routine appointments. Second, they would do telephone consultations. And that doesn't always work with acutely unwell patients. So that was a challenge to sort of, for example, you had to access cardiology, hematology, or other kind of acute treatments, which was challenging. I think it's still challenging, but definitely getting better. Coming back to how the staff dealt with all of this situation, I think I mentioned that there was fair, and they're still fair. On my ward, so my ward manager, she had to shield, so she was working from home, and clearly one of the leaders were down and working from home. That was one. Then many of the nurses actually had to isolate because either their partners, family, someone got infection. I personally was home for 2 weeks. And then the whole situation about traveling in public transport for some people, coming to work. I think everyone was doing their best. And I see something in healthcare staff is that I think obviously we need a job, but once we are at the job, we probably forget about ourselves, and it's just like you're just doing things selflessly. And there was also this thing that we got screened at whether we had got skills to deal with physical health. We had to answer questions that we can put in a tube, we can put in a line, we can do ABGs. And then they moved the junior doctors from psychiatry to the A&E setting. And as a result, one of my foundation doctors had to go. Interestingly, she was exempted because of some physical health reason, but she actually told them that, look, like any other doctor, I want to help, I want to go, I will do my best. And she actually went. So that was a challenge even because there was a point, I think I didn't have a doctor for a few days. Then we had to somehow get a junior doctor relocated for here and there to help with. Same happened with nurses. I think the numbers were down. There was also agency nurses or locum nurses who wouldn't come in for a period of time. And the challenge was we didn't know who was infected and who wasn't. Like I mentioned, we had 2 patients positive on the ward. I believe they got the infection from the staff because they were there for months and they were not going out actually. They became positive on the ward, which essentially was probably a asymptomatic staff member who had it. A few of our staff members were quite positive. One of our consultant colleagues was in ITU for, I think, more than a month or 2. Luckily, he got better, came back. Overall, in our trust, we were lucky. We didn't have any deaths on the wards, and the staff were safe. So there were no serious deaths, although people got unwell and they went into hospital. They came back. It did work well, but clearly we could see the burnout, and it is ongoing. Some of the things which I think probably did help, we at different levels, we do try to run a reflective practice group on the ward for the staff, which is not always easy for them to attend because they work in shifts, and when they are on a shift, it's not always them to take time out. And so our psychologist was doing that. We also, for consultants and body, we were having weekly Teams meetings with our CEO, whosoever wanted to attend. CEO meetings were open for everyone in the trust. We, as consultants, had a meeting weekly with the medical director, which actually was helpful. I think most of us were sometimes emotional, sometimes angry. sometimes frustrated. So everyone was talking about like, look, you're not doing this right. This is not happening. This should happen. There were not always answers, but I think it was good to sort of come together and sort of listen to each other from different, so inpatients, outpatients, and other specialties, what is happening where. And we also had our infection control nurse and the director of nursing who were looking at the COVID. So they used to do live team sessions probably every day in a way, and people could join in and kind of ask questions and get some clarity around things. One of our colleagues also, I wouldn't call it a balance group per se, but she ran a support group weekly for consultants to join in, which I believe was helpful for a period of time. Okay. I just wanted to sort of add a little bit about the mental health services. I think they are similar in Ireland as they are here. We have got community services, then obviously we have got urgent and emergency services and inpatient service. The reason I'm going to say this is that our trust started a new service, which I will talk about in a bit. So talking to community colleagues a little bit, so most of them stopped seeing patients and they were basically doing at the start phone consultations, and later on online consultations, something called using few of these apps, including Zoom and Attend Anywhere. And they had challenges, I remember, about clozapine clinics where people had to come in sometimes monthly or weekly to have their bloods done, and how to do that. They were trying to sort of see whether there would be any room to change the duration. And similarly, people on depots who had to have close contact was a challenge. Home treatment teams, which is another crisis type of teams here, who see patients in their homes every day if needed. They had greater challenges in terms of going to people's homes and not knowing, and also when people are unwell, how well they will behave or keep the distance. And there's also these questions about lack of PPE at the start, which was difficult for them. This is a little bit about the referrals. So there was really a fall in referrals at the start from March, April. So we were around 43% nationally in April. And now it's coming back, and there are more referrals now. They're saying there will be a tsunami of patients coming in. Same with home treatment teams at the start. It went down, and then in June it just came up, and I think it's going up now. Overall, I think with NHS, there was so much change and so much flexibility in so much short time. It was actually surprising. I remember we had this video conferencing system on the ward for many years, and every time we would probably not use it and would be hesitant. But suddenly we were so much dependent on technology that it completely made sense. Although I'm worried now that we may be using too much technology, and in psychiatry that's not always the best idea, because we may be losing the human touch of around this. So this whole digital and remote working became very much kind of part of it, and I think it's still ongoing, and we are still, even our teaching at the minute is online. We are having medical students supervision online. I'm also the undergrad tutor for St. George's. So just like you're doing the hourly session with the students or tutoring them online, things like that. So with these changes, what happened with our trust is that they decided to, rather than patients going to A&E. So normally if somebody is in mental health crisis, they will normally call 999, or the family will take them to the accident emergency, where liaison team will see them to start with, and then make a decision whether they need inpatient treatment, or they can go with home treatment team, or they can be discharged back home. So what they did is they started a service in the main psychiatric hospital, which is called Springfield Hospital, which is also based in Tooting, nearby to the main hospital, which is St. George's Hospital. They moved part of the liaison team to Springfield Hospital and started this service called Orchid Mental Health Emergency Services. So all the patients would directly go to this service rather than go to A&E. obviously they were triaging them a bit in terms of if someone was very physically unwell, so that one will be taken to A&E, but most of the other patients would get directly diverted to Orchid. And I think it started in 30th of March, and a few weeks ago, this is an old slide, they had seen almost around 600 patients now, which normally would have gone to A&E first, which is a huge number. And I think the local commissioning groups actually like the idea, and they have extended it. And I think it is one of the 2 services in the whole country which has been kind of praised by CQC and considered to be new service. Although we have got some concerns now that it may affect the parity of care, because sometimes you would miss our patients are complex, even when they have physical health problems. They don't say them straight away. And if we are taking them to a place where you don't actually do the whole physical examination, blood test, you don't have access to CT scan, MRI, we may be missing things. But overall, it worked well. So this service now, all the patients go there, they're COVID tested, is considered to be a COVID positive zone, essentially. Initially, they tried to have green zones and red zones, but then they thought it was difficult. And the staff there is in scrubs, is run by psychiatric colleagues and obviously junior doctors and nurses. So I think it was I just saw this NHS healthcare leaders update where they had praised the service as such. So it's still ongoing. A little bit, I don't think we have that much time, just on my ward and my personal experience. So lots of COVID-related admissions. I had a few patients who actually COVID on the ward then, although recovered well. Few other patients who would not follow the social distancing in the community. So they will go to their neighbors and other things and basically got picked up by police ultimately and got admitted. Many patients I have seen now are, because they're home, there's not much to do. It's like a big brother situation. There are conflicts in the family. There's some of them have taken to alcohol, some are using cannabis and stuff, and some of the admissions are coming that way. That's either they are relapsing in their psychosis or there's a new onset psychosis of some kind. Or if not psychosis, they are like acutely so much stress, like an acute stress reaction is that they are behaving strangely for a period of time or not sleeping, which sometimes kind of causes acute concerns, and they get on the ward. And one in groups or going elsewhere, that stopped. So there's clearly a trend where people are becoming very, very unwell. And because I haven't got that data here, I did another talk recently for Royal College of Physicians about effects of COVID on mental health. There's lots of papers now coming out, is that obviously there's like more than 40% population is stressed, and there's some kind of stress related thing going on, and some of them are coming into hospital. Finally, where are we now? I think, so we are supposed to be in the second wave. The numbers are increasing day by day in London. I think we were told that we'll be peaking again in a few weeks' time. At the minute, there's lots of changes happening. Though this time we are more organized, there are more testing available, and obviously there are more PPE. So we're on the ward, we are using masks now routinely when seeing patients. Also, we are testing patients weekly now. Although the irony of the situation is we are not testing staff, we are just testing patients, which makes some sense, but not sense, because anyone can have it. And some of the patients, they don't like to be swabbed every week. It's not a nice test, if it makes sense. Clearly, the organization is also ready around if things go wrong. I think now we know the pathways. Now we know how to refer people here and there. But I suppose there are still many unanswered questions around how it would work in long term, how the community services work, and if there is a tsunami of patients coming through to the mental health services, how that's going to be dealt with, given the resources, given the numbers already down, given there's already staff burnout. And obviously we know so many doctors, nurses, and other allied health professionals even died with COVID. And many had to sort of stay home for longer period of time because of health reasons. So that's going to be a challenge. I think I will stop here, and it would be good to hear from you if you have any questions or anything else. Thank you very much.
Thank you, Mudasir, for the presentation.
Thank you.
First of all, congratulations on your beautiful baby boy. Is he your first son?
Yes.
Oh, lovely, lovely. Well, we've been talking amongst ourselves in general, whilst there's huge angst around COVID and it has changed things a lot. For some people, and for the fortunate some, there has been a positive opportunity of being able to spend more time with family and to kind of change the way we had been on that fast pace for so long, to actually focus on what's important. So the working from home for a lot of people has meant that actually they have had more time at home with family. Now, in child psychiatry where I work, we know that can not always be a positive thing. Trying to work and having kids coming in and out, interfering with what you're doing, and not having that separation from home and work can also be stressful. But hopefully for you, it has been nice to see your little son grow a little bit.
It is, yes.
Lovely, well, congratulations. Could I just ask you about, you'd mentioned some of the COVID-related clinical presentations that had come to the hospital. I was interested to learn whether there had been a change in any other way, not so much either neuropsychiatry or COVID anxiety, but a change in the clinical presentations based on organizational change within the area. There had been a concern that with the shutdown, both in medicine and in psychiatry, with the shutdown of, clinics, usual care, that people would become much iller at home before they finally sought care. And I was wondering whether community clinics, if they had shut down their face-to-face assessments, whether that, and for those that aren't Zoom au fait or don't like technology, or if they're a little bit paranoid or suspicious, they may not buy into it. Did you see any change in clinical presentations or the nature of the cases you were getting that you kind of felt were very much linked with organizational change?
I think there was one observation, obviously, it can be a bit controversial as well. When this whole started in March, April, May, normally on my ward, I don't get many of the personality disorder diagnosis admissions or crisis admissions, but on the female wards and the mixed wards, the number of patients who would often come into hospital repeatedly, basically they completely stopped. Even the colleagues who are working in Orchid or A&E, they would say that those patients are actually not coming. And certainly there was this question, is that how are they coping? Or is the fear of COVID so great that you're basically coping better now and you're not like presenting crisis in self-harm or kind of overdoses and other things? So I think that was where most of the bed space came available. Clearly, when some people become psychotic, I think they have to come into hospital one way or other way. Either the families will call for help, or they would be found in places where they're not behaving the way they should. But I think in our trust, I don't think we had that difficulty. Clearly, the services were not working face to face, but home treatment team was working, who was still seeing patients at home, and they were available on phone and calls. So overall, no, we didn't had that much, apart from kind of at the start, the crisis admission type of patients were not coming much, but then gradually they started coming again.
And what is your thinking about the change in referral pattern? The initial decrease seemed to have happened everywhere, and there's, you showed the data there that it's not quite yet at the previous rates that it was last year. There's a sense from Irish psychiatrists that, again, after that first month, that after that there has been an increase in both numbers and acuity to services.
So there has been definitely, because we were at around July, August, we had no beds at all. And we were really struggling. The trust was in black and we are in red now, which means still we are at 100% bed occupancy and people are still waiting to be admitted. And I think I was talking to community colleagues similar, they're getting more referrals now. And some of them are quite clearly stress related. And obviously, I think what we haven't talked about, one issue here is that many people are losing their jobs. And there's kind of this economic cost of this whole pandemic, which is affecting people's lives indirectly now. And ultimately, I think that would affect mental health again. So there is a rise in referrals, both for inpatients and outpatients at the minute as we speak.
And in terms of the day-to-day management on the ward, you were saying that, you know, in the beginning you had access to PPE, and again, you know, the UK college survey that your college in the UK did, that was one of the biggest fears of the psychiatrists, that they felt they didn't have access to PPE. Strangely, wasn't a fear amongst the Irish psychiatrists, although I don't think the Irish were any richer in their PPE requirements. But in the beginning, when cases were coming in, were you doing consultations in full PPE, gowns, masks?
So there was no. I thought that was the problem at the start. There were not. So basically, what the guidelines were is that if there is some history, prior history, or someone is coughing and they have temperature, and you're suspecting there's COVID, then you think of PPE. Otherwise, you do you carry on as it is. So most of the times we no, it was just a mask, most of it, or a glove. Not more than that. Even when we had positive patients on the ward, and I will go to their room, sort of see them from the door from a distance. So it would be a glove and a mask. Not more than that. I think it's just being a medic, and once you do it repeatedly, then we become a bit used to, isn't it? Which is not the best idea always. So yes, that was it. I think we had the, what do you call those, visors and polythene gowns as well. But then I also saw that it's very hard for mental health services or people who work in mental health to follow all this, because our patients are very different. We're not dealing with someone, we're doing a half-hour surgical process or something. A chaotic patient on the ward who is going around, and you have to be with them all the time to keep them safe or keep others safe. And it's very hard for a nurse to be in that mask 24/7 or to be wearing all that. It just doesn't add up together. And also the concerns around some of our patients, if they don't see your face, there can be other issues in terms of they are paranoid or trust issues or engagement with you. So it's more complex than that. And clearly in England, I could think our mental health nurses are not trained in physical health. And even following how to use PPE was challenged at times, even when they have to wear a mask. As we all go into these days, we'll see it's usually on the chin or on the neck. It's a similar situation on the wards as well, even though the mask is there, it's not there.
So for most of the time when the nurses are engaging with the patients, they're not wearing a mask. They're trying to keep their distance and be safe otherwise.
At the minute, they are wearing masks, but I think if we're really looking at the way guidelines are, then it's hard to follow them. But I think they are trying. Well, I think one thing on my ward is because we test all the patients, and my ward is considered green ward. So I think that is a bit of a relief. But I wonder the wards where they don't know the status of the patient, things are more trickier.
And how reassuring is it to test all the patients but not test all the staff, the cleaners, the porters?
No, and I think it just obviously it probably makes sense at organizational level or national policy level, but it doesn't make sense on frontline, because if I am testing all my patients and I'm not testing my staff, basically I think it should have been personally other way around, because the patients are based on the ward. They don't go out much. They don't travel in public transport. The staff comes from distance, they travel in public transport, they meet other people. So essentially they should be tested more to keep the patients safe. But I don't think we could, there are pros and cons on both sides. But essentially, I would have thought that everybody should be tested if they are working like this. But maybe in future that would happen when more testing is available, but it's not happening as yet. Just to add access to tests. So week before last week, we had a flu at home basically. And then my GP told my wife that I shouldn't go to work. I should self-isolate because I know I had temperature. Then clearly I was well. I clearly thought it was flu. There's nothing COVID. Then I had to book a test through the national website, and it took me pretty much 6 hours to book the test for all of us. Because there's no testing available. Right? Many people are taking tests at the minute, which I think now they are trying to book tests through the hospital itself, but it's not as easily available, because normally because we can test our patients anytime, we could be able to test ourselves. That's not the case. So you have to follow the routine kind of procedures to get tested.
Could I ask you, Mudasir, you were mentioning about the mesh services, about kind of diverting or the services we're thinking of diverting acute psychiatry presentations from ED. I'm imagining that's partly to both prevent overload of the hospitals in anticipation that the hospital was busy, but also perhaps to protect the psychiatry patient from exposure unnecessarily to higher COVID prevalence.
I think the idea was to have A&E at the start, because it was supposed that it was very busy. So to rather than acutely unwell psychotic patients going to A&E and waiting there for mental health assessment, which sometimes takes like 10 hours, because you have to get a social worker, second opinion doctors to divert them directly to a facility where they can be seen quickly and things can be done. So I think that was actually the idea.
Initially. Yes. One of our attendees, I think it's Dr. Charles Byrne, had asked whether you see a role for these services post-COVID. You know, are there benefits to that?
So we had a couple of meetings, obviously in the consultant groups and the people, consultants, colleagues who are working there. I think overall people are worried that it will take something away from our patients. They would be kind of seen not to be going to A&E when they should really go to A&E for any problem. And if there's already not much parity, and still people when go to accident and emergency, and if they have a mental health history, they're sometimes dismissed that, well, their pain or whatever symptom they are presenting is because of their mental illness rather than physical illness. And it would again create another level of segregation. So I think most colleagues think that we should go back to how things were, because there are liaison teams anyway in the A&E and they can see them. But I think the commissioners are happy with the situation and they have extended their funding for 3 more months. So we'll see how it goes. Yes, overall, I think they did well. They managed kind of, most patients were managed outside settings. I didn't say because our trust caters to few boroughs. It's like Wimbledon, Wandsworth, Kingston, Richmond, Sutton, Merton. So it's a big population area. And there are few general hospitals in the area. So most of these patients did manage not to go to A&E. So there is a role, there is not a role. I think it's how we look at it. Clearly.
And I guess
they had worried that they had actually missed some patients who actually needed to be having full, thorough medical examination, investigation. I think there were few cases who would have benefited being in A&E, but I think nothing major, I suppose.
And I think that we all know about the lack of parity between medical and psychiatry cases. And, you know, it's so important not to inadvertently come up with a solution that is started and commenced for the person's good. But actually, as you've said, you may miss a need for an organic screen, or they may be felt like second-class citizens, even though, you know, that wasn't the issue. You mentioned earlier in your discussion about in the beginning, limiting visitors for those that came to your unit. And I work in a pediatric hospital, and in the beginning, our hospital policy had been, again, trying to limit footfall into the hospital and limit exposure to asymptomatic carriers, that visitors were restricted to just one parent per child. And the difficulties I saw, you had parents who were really worried about their children. They were in a stress situation where having the support of the other parent to co-parent and support was so important. But then they'd left all their other children at home that needed the mother or the father, whoever was the designated person. And the relationship between the child and the parent that was just designated to be there wasn't always necessarily the best. And it was a real ethical challenge that we faced to go along with that, particularly in the cases of children who had eating disorders, where the intensity of the, you know, both treating the young child, but getting the parents to be supervising the meals and, you know, facilitating that, the stress level on the parent who was left in the hospital was huge. And you could argue that that was unethical from both the parent and the child's perspective. Similarly, in the adult, you described there where families were so worried they were, coming outside to try and see the patients. Do you think that in a way, because it is quite different psychiatry and where getting better is so dependent on that family support and, that really in a way we should have thought more about that and coming up like you did with arrangements where, you can set up a safe, because we now continue to have family meetings where we invite the parents in and we're just much more careful about the room, the space, the masks, the ventilation. Do you think?
Yes, I think I agree. Obviously, I think that was the confusion, is that we should admit that nobody knew what was happening. It was all new, and we were taken away. It's like a storm coming in. So at the start, guidelines were changing from top to bottom every day. There was not much clarity, and also we didn't know much about the virus, its behavior, how people get unwell. I think now things are a bit more clearer, that it's not like simply when someone has COVID and you pass by, you don't necessarily get it. You need to spend some time with them. Also about, as you said, distance and PPE. So I think things are a bit more clearer, and also people in general have also more knowledge about what's happening, how things are. Because at the start, like professionals, I think general public had also limited knowledge, and clearly there was more fear and more emotion associated with it rather than now. So I agree. So that's what we are doing now, is that we are actually trying to sort of, if we have to do face-to-face meeting, we are doing them, and if telephone consultation is okay, then we do that, but we don't stress that don't come. The one thing I think I didn't mention is that sometimes we send people on leave for a few days, a few nights, and then discharge them just to make step by step. That also got stopped because I think once you send someone for a few nights, you can't admit them back. It has to be testing. So there's still kind of disruption on that. But overall, things are working. But at the same time, I think some people are, we all as human, we are fed up of this, because it's every day you have to sort of, the first thing is that thinking about pandemic and how to keep safe. And this is just an additional thing which you are doing on top of everything else. And I think also patients, and you can see staff being fed up now that enough is enough, but it's still there. We don't have the vaccine. So hopefully something will come through.
Well, Mudasir, that sounds like an absolutely excellent segue into what will be one of the later slides that I'm showing, which is about our occupational burnout conference that we're having next week. I mean, you spoke there about, you're continually coming into work, you're worrying about family, you're worrying about contacting the virus yourself. And one wonders just how long as clinicians, and particularly as those maybe within the psychiatry field, how long we can, have resilience to be able to deal with all of these, on top of what you spoke about was the tsunami that's about to happen of the increased referrals. Mudasir, thank you so much for that very, very interesting insight into an acute inpatient psychiatry unit in the UK. And, hopefully we will stay in contact. I know we'll chat with you in the chat room afterwards, but
thank you very much. It was a pleasure.
Yeah. Can I draw everybody's attention to the Occupational Stress and Burnout Conference we're having? Although it is specifically focused on healthcare workers, as we've been working through the talks for it, the realization is that the only thing that's different in other fields, like, it would be equally pertinent to commercial groups, to other sort of non-clinical groups. But obviously, I think we must realize that we carry with us that extra clinical load where we have a unique duty of care to the patient, along with whatever care to ourselves. So please do consider joining us for that next week. The link is there. Paul is the next speaker then after that. Have you got a slide for that? The week following that, we're back to our normal webinars at 12:30. So next Friday, it's a 9:30 start, anybody who's going to join us. And so the following Friday on the 23rd, we'll have psychiatry and neuropsychiatry presentations. We've heard a lot about these from SARS and MERS, and not really that much yet with regard to COVID. So I think Dr. Rogers' presentation will be very interesting, and again, join us for that. And I think we also have another event that we're hosting. You might remember that at the beginning of COVID, Blonid, myself and John Lynn, you know, asked many of you to contribute to a special edition of the Irish Journal of Psychological Medicine to capture not just the Irish COVID experience, but an international experience as it was breaking. And there's a huge amount of very innovative ideas, just like Mudasir was talking about his unit. Our own inpatient psychiatrists have also contributed. So we are planning to actually give you a little bit more flavor. The hard journal is about to be published, and hopefully you'll all get a copy of that. But we're hoping to give you an opportunity to join us with some of the presenters and the authors of those pieces on the 23rd of October. That'll follow directly after the neuropsychiatry webinar. And I think the last plug, and thank you all for staying with me, is a primary care mental health graduate program that we're running at UCD. And I think certainly increasingly now with COVID and with the longevity of the restrictions, we're just so aware of how everybody needs to know about mental health. So GPs are facing it every day of their week now more than ever. So this is something that they might be interested in considering. So I think that's it, everybody. And we're going to go to the chat room, and everybody else have a great weekend. See you next week.